By way of definition, when you say acute appendicitis, it's defined as the transmural inflammation of the vermiform appendix. So the inflammation extends throughout all the layers of the appendix. So the inflammation is not only in the mucosa, the muscular layer, or the serosa. It involves the entire layer of the appendix. So that is appendicitis. And the relevant anatomy, you know, the appendix is located in the right iliac fossa. The base of the appendix is attached to the cecum. And of course, there are various positions of the appendix. Some of the appendix are located retrocecally, some subcecally. You have preilial, postilial, paracecal, pelvic. But majority of the location, about 75% of the appendix, is retrocecal. Then about 21% is pelvic appendix. Okay, so you should know that majority of appendix are retrocecal in position. And this actually determines the way they present. Now, we also know that appendix, before it was considered as an organ that doesn't have any function. However, it has its own immunological function, okay? Because it secretes immunoglobulin A, okay? And it's a component of the gut-associated lymphoid tissue, okay? Now, however, this organ, when it is inflamed, it is removed to avoid serious complications that may follow. Now, acute appendicitis, as we said, is a transmural inflammation of the vermiform appendix. And you should know is the most common surgical emergencies. It's the most common of surgical emergencies. Of all the emergencies that present to the surgical emergency department, acute appendicitis accounts for the highest. And it peaks usually in young adults and during puberty. It is rare in the extreme of ages. It is rare in the neonatal period, as well as in elderly. And you should know that the diagnosis in this extreme of ages, especially in the neonatal period, is very difficult to make because the symptoms of appendix, the diagnosis is usually clinical. And you know a neonate cannot give you that history, and you cannot demonstrate the signs of acute appendicitis in a neonate. So usually in the neonatal period, when they present with appendicitis, which is very rare, the diagnosis is usually at operation. And it is commoner in males as compared to women. And you know, there are various types of appendicitis. It could either be obstructive type, or catarrhal types. Now, the obstructive type, usually there is obstruction at of the lumen of the appendix. And the various causes of obstruction, the commonest cause is by fecal leaf. When a fecal leaf obstructs the lumen of the appendix, it causes increase in intraluminal pressure. Of course, this increased intraluminal pressure will exceed the venous pressure. It's going to cause venous engorgement, ischemia, necrosis, and ultimately perforation. And patient will present with generalized peritonitis if that inflammation is not contained. Now, what is this fecal leaf? Usually, you have shaded epithelium that have been calcified, containing calcium, phosphates, some other mineral nutrients, dead epithelial cells, and some fecal particles. They form a stone-like material that gets inspissated in the appendicular lumen and cause obstruction. Now, since we said appendix is a lymphoid tissue, there could be hypertrophy of the lymphoid tissue, and this will cause obstruction of the lumen. Now, it could be from an inspissated barium, vegetable or fruit seeds, which is very rare, intestinal worms like Ascaris lumbricoides, and some tumors. This could be tumor arising from the appendix itself, or tumor arising from the cecum, or it could be an extraluminal. I have a patient recently, I think last month, a middle-aged man who presented with ectopic kidney in the right iliac fossa, and patient presented with acute appendicitis from extrinsic compression, and it caused a diagnostic dilemma in the patient. So you could have tumors that are in the pelvis, which could cause extrinsic compression and ultimately leading to acute appendicitis. So what you should know, the obstructive type usually is the predominant type or cause of acute appendicitis. Now, these are the sequence of events which occur. We said when there is luminal obstruction, let's say with fecal leaf, okay? So there is proximal occlusion, which will appear like a closed loop now, okay? You have the appendix, and this is the cecum. Then maybe the fecal leaf block these at the base. So there is a proximal occlusion, and it forms a closed loop here in the lumen. And this will cause rapid distension, okay, due to continuing secretion by the mucosa of the appendix. There is continuing secretion by the mucosa inside the lumen. And because there is stasis, okay, because there is stasis here, there is rapid multiplication of the normal flora within the lumen. And this leads to elevated pressure and the elevated pressure causes capillary and venous occlusion. There is venous congestion, which leads to capillary stasis. And when there is capillary stasis, there is going to be ischemia and necrosis, followed by perforation. Okay, so the congestion is the first stage. Now, you should know that anytime you have stretching of the viscera, there is stimulation of the autonomic nerves, the pain fibers. Okay, you see the visceral afferent pain fibers that present as a vague, dull, diffuse pain in the mid-abdomen or lower epigastrium, because you know the appendix is a mid-gut structure. The pain is usually around the umbilical area. For a foregut structure, visceral pains arising in the foregut usually are in the epigastric area. Visceral pain arising from the midgut are usually in the periumbilical area, and visceral pain usually arising from the hindgut are in the lower abdominal area. So this vague pain that is felt is usually periumbilical because they have the same nerve roots, which is T10. Okay, the T10 is the same nerve root to the umbilicus. So this pain is due to stretching of the mucosa, okay, stretching of the muscles, as well as increased peristalsis that cause cramps. And in this stage, patient will have nausea and vomiting. So what causes vomiting at this stage? When there is stretch of the mucosa in acute appendicitis, there is a reflex pylospasm. There is a reflex pylospasm of the stomach. That is the pylorus of the stomach. And when it contracts, the patient empties the gastric contents. That's why the vomiting is just once or two times in acute appendicitis, because of that reflex pylospasm, which usually is one episode or two episodes of vomiting of recently ingested meal. When you see a patient having persistent vomiting of bilous effluent, usually it is a complicated appendicitis or peritonitis from other causes. Now, inflammatory process involves the serosa of the appendix and in turn the parietal peritoneum in the region. So now, as this inflammation progresses from inward outward, it involves the mucosa, the muscularis, the serosa. Inflammation of the serosa now, because that parietal peritoneum will now be in contact with the visceral peritoneum, which is the serosa that is inflamed. That will now stimulate the somatic innervation, because the parietal peritoneum has somatic innervation. So they will now present with pain, which is now dull, okay, and sharp pain. okay? Unlike the visceral pain that sometimes is dull and not very intense and sharp. But here the patient will present with a dull and sharp or sharp pain, and he will have tenderness in the right iliac fossa. Unlike the visceral pain that is associated with some abdominal cramps because of the obstruction that is causing peristaltic waves. Here you have a dull pain in the right iliac fossa, okay, or sometimes that it is more intense. So there's infiltration of that appendix by the polymorphonuclear cells, the neutrophils. So in order to fight the infection at that site. So the infiltration of the white blood cell to that area in fighting the infection. Some of the cells are killed, some of the bacteria are also killed, and the shedding of some epithelial cells which collectively form pus. So there is suppuration in the second stage of the pathogenesis. So you see initially there is congestion, this progresses, and the subsequent suppuration after infiltration by white blood cells. Okay, so there is damage of the lining epithelium, and you have entrance of bacteria to the wall. Now, impairment of blood supply, as we mentioned, there's increased pressure which exceed the perfusion of that appendix. Then there's ellipsoidal infarct at the antimesenteric border near the tip, and there's it progresses to gangrenous stage, and ultimately there is perforation. Now, the commonest site where you have perforation is at the tip of the appendix. Now, you should know that this process is not inevitable. Sometimes it may subside spontaneously. Now, what are the pathogens that are associated with this infection? There are several microorganisms, several bacteria that are implicated in the pathogenesis. Anaerobes, aerobes, Bacteroides flagellis, E. coli, okay? And you have the Peptostreptococcus, Pseudomonas, Bacteroides, and so on. There are several bacteria that are involved. Now, abdominal pain, these are the clinical manifestations of acute appendicitis. They have abdominal pain, okay? And we describe the pain as a migratory right iliac pain. The classical sequence, it starts from the periumbilical area and migrates to the right iliac fossa. Now, we mentioned, why does the pain start from the periumbilical area? It's because the periumbilical area and the appendix have the same nerve root. At the time where the appendix is inflamed, when there is visceral pain at the point of congestion of the appendix, okay, there is a referred pain to the umbilical area because they have the same nerve root of T10. So later, when the inflammation has now involved the serosa of the appendix, and the serosa is now in contact with the parietal peritoneum in the right iliac fossa, this pain is now localized. That is now a somatic pain. So it is described as a migratory right iliac fossa pain. The initial periumbilical pain is a visceral pain, okay? And the later right iliac fossa pain is a somatic pain. Now, acute appendicitis might present with other pain. This is the classical presentation. However, there could also be some other forms of presentation. They could have a left lower quadrant pain in a long appendix. They could have flank or back pain in a retrocecal appendix. They could have a suprapubic pain in a pelvic appendix. They could have a testicular pain in retroileal pain, which irritates the spermatic artery and the ureter. Now, aside pain, there is anorexia. Don't forget, anorexia is the most constant feature in acute appendicitis. It is nearly always present. Any patient with acute appendicitis and you see him munching a bowl of food, you should be doubting that diagnosis. When you see a patient with acute appendicitis, they almost always don't have appetite, okay? And of course, when you ask them of their favorite meal, okay, and they tell you, and you now ask them if they have appetite for that their favorite meal, they will tell you no. And that is a positive, what sign? Hamburger sign. Now they vomit. Vomiting is usually seen in about 75% of patients with acute appendicitis. However, this vomiting, as we mentioned, it is not frequent. 1 or 2 episodes of vomiting, which is of recently ingested meal, non-bolus, and this is as a result of pylorospasm. Now, they could have obstipation in some condition, or they may have diarrhea. They have diarrhea when the appendix is pelvic, irritating the rectum. Now, they may also have increased frequency of micturition. Increased frequency of micturition is in pelvic appendix. When pelvic appendix is irritating the bladder, the tip of the inflamed appendix is irritating the bladder, they may also have frequency of micturition. Now, you should know the usual sequence. They have anorexia, abdominal pain, and vomiting in up to 95% of cases. Now, what are the signs of the acute appendicitis? Okay. Now, when you ask the patient to point, okay, exactly where they are feeling the pain, and they point to the right iliac fossa, That is called a positive pointing sign. Okay? The first thing you ask the patient, can you point the site of maximum tenderness? And when they point to the right iliac fossa, that is a positive pointing sign. So you should also know that the physical examination depends on the location of the appendix, okay? And it also depends on whether the appendix is intact or it has ruptured. Now, direct and rebound tenderness at the McBoney's point. Now, when you palpate the right iliac fossa, there is tenderness in the right iliac fossa. When you suddenly lift up your hand from that deep palpation and patient feels pain, that is rebound tenderness. Ruffin sign, positive Ruffin sign is palpation of the left iliac fossa and patient feels pain in the right iliac fossa. Now it indicates muscles and peritoneal irritation, because when you palpate on the right iliac fossa, it displaces the abdominal viscera to impinge on the appendix as well as the parietal peritoneum and the anterior abdominal wall. Patients have pain. Now they will have involuntary muscle guarding, which is true reflex rigidity. Now, signs of peritonitis include rigidity, guarding, okay? When you say guarding, patient voluntarily contracts the anterior abdominal wall to limit pain during palpation, okay? When you say rigidity, it is an involuntary contraction of the abdominal wall, and it is due to spasms of the muscle of the abdominal wall. So the guarding is an active process, while rigidity is a passive process. Guarding is voluntary, rigidity is involuntary. Now, they could have positive psoas sign or obturator signs in erythrocecal appendix and pelvic appendix. So when patient is placed on a left lateral position with his hip and knee joint in an extended position that is straight, and then the hip is now subsequently hyper extended and patient feels pain, that is a positive psoas sign. When the patient is placed supine and the hip joint is flexed, the knee joint is flexed, and then the hip is now internally rotated or externally rotated, and patient feels pain, that is a positive obturator sign. When you do a digital rectal examination and you palpate the right side of the rectum, you feel and patient feels tenderness, that is a positive pararectal tenderness. Now you should know that the diagnosis of acute appendicitis is clinical. The laboratory investigations are supportive. for the diagnosis of acute appendicitis. We are going to see the Alvarado score, where you have diagnosis that is unlikely, equivocal, and diagnostic. So all the category of patients that fall in the equivocal range, you have to do ultrasound scan or other investigation to confirm. But you should know that the diagnosis of acute appendicitis is clinical. White blood cell count, you should know that in simple acute appendicitis ranges from 10 to 18,000 per millimeter cube. However, if it progresses to perforation, the white blood cell count might go beyond 18,000. Now, urinalysis check for hematuria, pyuria due to irritation of the ureter and bladder. Okay? Now, you will not see bacteria in the urine. Okay? So, in this, it is due to irritation. That's why they may be having hematuria. And in such cases, patients might also be having increased frequency of micturition. Now, plain abdominal X-ray. Plain abdominal X-ray. They may show fecalith. It's rarely helpful and it's not routinely requested in a patient with acute appendicitis. It may show fecalith, which is highly suggestive of acute appendicitis. Okay? Now, the ultrasonography, the ultrasound scan for acute appendicitis have high diagnostic efficacy. Okay, it has a high diagnostic accuracy for acute appendicitis. You can see the sensitivity is 78 to up to 96%, and the specificity is up to 85 to 98%. Okay, what are the findings on ultrasound scan that suggest a patient have acute appendicitis? So you should know that anytime you are reviewing an ultrasound scan result, there are some certain features you will be looking for to diagnose acute appendicitis. Most of the ultrasound scan that come, they will just say normal scan. You write a clinical report looking for acute appendicitis. The radiologist or the radiographer scanned, and without even reporting anything about the appendix, without even visualizing the appendix, without telling you all the positive or negative findings, and normal scan. You see, in such cases, you should repeat that scan and write a good clinical details so that they know what you are actually looking for. Okay, so you have positive non-compressible tubular structure in the right iliac fossa. So there is a presence of a non-compressible tubular structure, aperistaltic, in the right iliac fossa. Now, that is greater than 6 millimeters in diameter, okay, at the anterior posterior view. So you have a tubular aperistaltic hollow structure in the right iliac fossa with anterior posterior view, a diameter of greater than 6 millimeters. And the reason why this luminal diameter is more than this is because of the obstruction because of the obstruction, there is going to be dilatation of the lumen. Now, easily compressible, less than, okay, 5 millimeter, not visualized, okay. So when you have a periappendiceal fluid collection, okay, is also diagnostic of acute appendicitis. You have a periappendiceal fluid collection. Now, if you look at this image, you can see a dilated lumen, okay, and you can see some periappendiceal fluid collection. And the probe, it's non-compressible. So when it is easily compressible, it's negative. When it is less than 5 millimeter, is negative. You don't visualize the appendix, okay? When there is no periappendiceal fluid collection, it's likely negative, or when there is no mass. Now, sometimes you might have difficulty in visualizing the appendix, okay? When the appendicitis is confined to only the tip, when it is in a retrocecal position, or when it is already perforated, you might have a false result. You have a false negative result while it is there. Now, you could have a false positive result reporting a positive finding when there is actually no appendix, when there is a periappendicitis, okay, from surrounding inflammation. Sometimes even a patient have peritonitis from typhoid perforation. You will just see a periappendiceal inflammation, even though the appendix is not inflamed. It's just a form of serositis, because appendicitis have to be a transmural inflammation of the appendix. There could be a dilated fallopian tube, and which will be falsely reported as acute appendicitis. You can have inspissated stool, which can mimic acute appendicitis. Now, in obese patients, because of the thick anterior abdominal wall, you might not be able to compress the appendix, and you are reporting it as a non-compressible structure. Now, to avoid all this diagnostic dilemma, the gold standard for the diagnosis is actually abdominal CT scan. But because of the limitations of the use of abdominal CT scan, it's not routinely requested for because of delay and also the expense. Now, the diagnosis you should know of acute appendicitis is usually clinical, except when there is diagnostic dilemma. You might have diagnostic dilemma in some very obese patient, morbidly obese patient, and some other conditions where you have diagnostic dilemma. Now, the role of laparoscopy is diagnostic as well as therapeutic. Now, if you have diagnostic dilemma and you can also do diagnostic laparoscopy. The advantage of diagnostic laparoscopy over CT scan is when you confirm that this is an appendix, you now treat it at the same time. So it's diagnostic as well as therapeutic. It's useful for female to differentiate gynecological pathology. Now, when this appendix ruptures, there could be increased morbidity and mortality. Okay? They will present with generalized peritonitis if it is not contained by the omentum. Now, there is no accurate way to determine the occurrence of rupture, but it should be suspected if they have fever of greater than 39 degrees Celsius, white blood cell count more than 18,000, okay? There's a localized rebound tenderness and guarding, or signs of generalized peritonitis. When there is an ill-defined mass, which is a phlegmon, there is mottled loops of ball adherent to an inflamed appendix. When you say phlegmon, the inflamed appendix, okay, is walled by ileum, okay, is walled by ileum as well as omentum also. The reason why this does that is the body protective mechanism to prevent spread of the infection to other parts of the abdomen. So it is called phlegmon when you have a mass that the appendix is walled by the ileum and the omentum, and it has some micro abscesses within it. That inflammatory mass is called a phlegmon. So differential diagnosis. Differential diagnosis. Most common erroneous pre-op diagnosis include acute mesenteric lymphadenitis, non-organic pathologic condition, acute pelvic pathologic conditions, twisted ovarian cyst, ruptured graphium follicle, acute gastroenteritis. Okay. Now, you should have a way of differentiating these conditions from acute appendicitis. You should also know that any young lady that is presenting with features of acute appendicitis, you consider a long list of differential diagnoses, and in them, ultrasound scan is also indicated because there are conditions that are arising from ovary, fallopian tube, and also the uterus, and you have to rule out all those conditions. Now, in acute mesenteric adenitis, they may have, okay, recent urinary upper respiratory tract infection, okay? So they have diffuse pain, tenderness, okay, and it's not sharp. Okay, gastroenteritis, which are, you can see in childhood, viral gastroenteritis, they have chills, rigors, watery stool, and so on. Diseases in male, torsion of the testes, okay, acute epididymitis, okay, diagnosed by palpating the enlarged tender seminal vesicles. In Meckel's diverticulum, they have same clinical picture with acute appendicitis, okay? Now it's associated with same complication of acute appendicitis, hence need prompt surgical interventions. Intussusception also is a differential diagnosis. Okay, the slide will be shared where you will go through all these differential diagnoses. Now, when patient presents with acute appendicitis, don't forget, resuscitation in any surgical emergency take precedence over investigations. They are adequately hydrated, correct electrolyte imbalance, manage other medical conditions patient may come with, okay, and you have to commence preoperative antibiotics, okay. Now, the surgery for acute appendicitis is appendicectomy, or as the Americans call it, appendectomy. So, which could either be open or laparoscopic. Now, the detail of the surgery is for another lecture. Now, you should know the prognosis, okay? The mortality is 9%, which have been reduced to 0.2%, okay? And the factors, you have ruptured prior to surgery, they will have worsened prognosis. In simple, you see it is 0.06%. When it is ruptured, the mortality is 3%. Age of patients. Now, extreme of age usually have poorer prognosis, and you can see in 15% will even present with rupture. And this is due to diagnostic dilemma, and death in patient with acute appendicitis is due to uncontrolled sepsis, okay. Patient with cardiopulmonary problems, like in elderly patients, pulmonary embolism, okay. And patient that aspirates. Now, morbidity for simple appendicitis is seen in 3%, while for ruptured appendix, the complication rate is up to 47%. Now, the early complications include wound infection, which may progress to form abscess. They could have intra-abdominal abscesses. They could form fecal fistula, especially when there is associated typhlitis, when there is inflammation of the cecum. They could have wound dehiscence. They could have intestinal obstruction due to loculated abscess or exuberant adhesion formation. The late complications will include adhesive bands, inguinal hernia, 3 times greater in patients who had appendectomy due to injury to the ilioinguinal nerve that is supplying the posterior wall of the inguinal canal. They could have incisional hernia. Okay, so we mentioned this already, that in the young, it is difficult to diagnose due to inadequate history, okay, and there is delay in both presentation by the parents and for the physicians to make diagnosis. Most of the diagnoses are made intraoperatively, and they have a higher complication rate. Now, you see appendicitis during pregnancy also could cause diagnostic dilemma. Sometimes because with growth of the uterus, you know, there is displacement of the abdominal viscera upward, and usually they present as acute appendicitis in pregnancy, and the treatment is surgical. and most frequently is during the first and second trimester. So this image shows the various positions of the appendix during pregnancy. So the risk for surgery, there is a premature labor in 10 to 15% of patients. There is risk of fetal mortality in 3 to 5% in early appendicitis, and that increased up to 20% following perforation. So suspicion of appendicitis during pregnancy should be treated promptly with surgical intervention. Okay, so we are going to take a break here. When we come back, we are going to talk about the Alvarado score, and also we now go ahead to talk about to discuss the MCQs. So we are going to stop here for now. We'll take break and resume by 7 p.m. and continue with the discussion. Thank you.